o'clock, so we're going to go ahead and get the meeting started. Good evening, everyone, and welcome to the August edition of Westhuizen Clinical. Welcome to everyone, and thank you for joining us here today. We're very privileged today to be joined by Dr. Nicole van Westhuizen. Dr. van Westhuizen is a specialist general surgeon at Netcare Olivedale Hospital. She completed her undergraduate degree at the University of Stellenbosch, and after that did her community service. After community service work, she did various work in emergency units across Gauteng, including Netcare Olivedale. She is trained as a specialist general surgeon at the University of Pretoria and did her master's dissertation on the factors that predict sepsis control in the surgical management of diabetic foot at Victoria Academic Hospital. Tonight, she will be discussing on the topic of the pathophysiology and treatment of diabetic foot, and we're very grateful to have Dr. Nicole presenting to us. Please note that this meeting is being recorded. You're welcome to type your questions at any point during the meeting into the chat. We will get to the questions at the end of the presentation. We'll have some time to just get through the questions, but you can type them at any time during the meeting. And without any further ado, I'm going to hand over to Dr. van Westhuizen. Thank you so much.
Thank you so much for the warm welcome, Mrs. Kiwana. I really appreciate the opportunity to share my experience with diabetic foot and also my experience with diabetic foot sepsis and the involvement of the surgeon in this setting. Thank you. I'm going to go ahead and share my screen. I hope you're happy with that.
Yes, please. I'll let you know once I can see it. Okay. Do you want to just, yes, you can start. That's perfect. Yeah, we can see your screen.
Thank you so much. So I guess we can jump right in if you're happy. I am a specialist general surgeon, as Ms. Kiwana said, at Netcare Olivedale Hospital. I'd like to discuss the pathophysiology and the treatment of diabetic foot today. So we'll start from the beginning, and it's quite a long walk. So please take this walk with me, and we'll both just learn our teams in this disease, our places in the team in this disease process. So Leonardo da Vinci did say that the human foot is a masterpiece of engineering and a work of art, and he was completely right. And when we look at the foot, especially when it comes to diabetes mellitus, we want to know that diabetes is a disabling condition. It's poorly understood by the patient and sometimes even poorly understood by the doctor. And as I did my study in septic factors that affected diabetic foot in Pretoria hospitals, I really had a look at why these patients had a high admission rate, why they had a high amputation risk, and why it was quite difficult to eliminate sepsis in these patients. So readmission was definitely linked to hypertension, to metabolic syndrome, to cardiac disease, which was further impacted by the infection in these patients. So mortality risk definitely increased with the worst presentation of infection. These patients have high rates of limb loss, high amputation rates, especially major amputations. And then amputation was a very poor predictor for return to activities of daily living, and we can see why. We use our feet to do everything, and we contribute economically by being able to work. And these patients are often the providers in their family, so we want to prevent this. So patients really have a high lifetime risk of developing an ulcer. When we looked at studies, we saw about 15 to 30%. A lot of these patients had a high mortality risk with multiple amputations. So the mortality risk at amputation rate was calculated, and at 5 years, the mortality risk was about 50%. Re-amputation also constituted a higher mortality risk. At 5 years, we can see that it increases rapidly and exponentially there. Patients with previous limb amputation had actually a high risk of re-ulceration, and we can note there that actually these patients shouldn't be lost to follow-up. They should be followed up lifelong and checked lifelong. We can see that the amputation risk was about 60% over 10 years if you've had a previous amputation. And often we forget that patients with microangiopathic compromise, like peripheral arterial disease, come back and they require multiple amputations, and they do also have a higher risk of dying from these operations. So take a walk with me through my multidisciplinary diabetic foot clinic. So we really think that a multidisciplinary clinic makes sense for these patients, because they typically get lost to follow up. With one specialist approaching one side of the disease, you can't win. So Currently, we don't have many multidisciplinary clinics for diabetic foot sepsis in the country. We're really starting something at Netcare Olivedale that will help us with these patients and prevent the high admission rate in these patients, and also pick them up quite early. So I want to discuss several things here. I want to discuss the paradigm shift in the management of diabetes, the pathophysiology management plan, how to initially assess the patient, what your approach should be, how to score the foot and how to treat infections, and then how to present a tailored treatment plan. And I'd also like to just introduce my clinic and my specialists who are involved, so that we can see that everyone plays a part and that everyone's part is then valued, and then also helping the patient in the long term. So there's definitely a shift to general treatment of these patients. I mean, we were taught as surgeons that the patient needs early amputation, and that's not incorrect, but the correct thing should be that amputation shouldn't be the end point of management. These patients come back, they have a higher amputation risk. They need chronic follow-up. They need foot scoring, bespoke treatment, and surgical intervention. And we really want to, instead of providing a blanket approach to these patients, just look at them individually, see what their risk factors are, what their diabetic control is, and how they should be managed in future and intervened upon. So the pathophysiology of diabetic foot is quite complex. There's a complex interplay, as we can see, between the foot and the environment. So the disease process definitely plays an important role. Your glucose control, your HbA1c, the risk factors that go along with that, and then your comorbidities as well. We know cardiac comorbidities, peripheral vascular disease, these are important comorbidities that we need to look at and we need to decrease. We know that these patients also have concomitant peripheral arterial disease, and they often have a peripheral neuropathy. Now, peripheral neuropathy can occur in more than 30% of patients. These patients have dry skin, they have decreased sensation, they have increased risk of unnoticed trauma. And unnoticed trauma can really happen overnight with these patients and progress significantly because of their difficulty to control an infection, even a minor infection. So the immune system and the fact that there is immune dysregulation definitely affects their ability to control the infection. So they should be monitored from all aspects in that sense. So our management plan consists of an initial management and a risk factor reduction. We look at the patient, their HbA1c, their risk for metabolic diseases, and their risk for cardiac disease. We refer them to several specialists as we see the need fit. We score the foot as well. So we look at the foot. Is there any pressure points? Do they have micro abrasions or cuts? Do they have nail or skin abnormalities that we can see? And after scoring the foot, we can then decide on the team management. So the team sits down and we look at the foot. We all intervene as we present the patient, and we see what the patient requires from each side of the team. And then the patient is then provided with a tailored treatment plan which assists them in their specific difficulty. So our initial assessment, we initiate care from a primary level, and that's where we really want to educate the patient, control the glucose, and prevent complications. So we want to do our history and our examination, and it's important to find out what work the patient does, how they live their life day to day, and how they manage their comorbidities. Yes, their sugar might be controlled, but they have hypertension and cholesterol issues, which put them at risk for peripheral arterial disease. A lot of these patients are unworked up. The diabetic foot ulcer might be the first presentation of major problems. We can do basic lab tests and radiology at this point, and we know that often these patients do have a staphylococcus infection of the diabetic foot ulcer. We want to make sure that we look at the wound, we make sure that there's no infection. If there is an infection, we do a swab for the patient. We make sure that we do bloods for the patient. We look for elevated white cell counts and CRPs. Basic radiology definitely helps me in assessing the patient initially. So I really want to exclude all the danger signs. I want to exclude that the patient doesn't have a Charcot foot, that they don't have osteomyelitis, and that they don't have gas gangrene related to necrotizing fasciitis. Unfortunately, necrotizing fasciitis is way too common in these patients, and often increases their mortality significantly. And then we want to screen for other diabetic complications, renal disease, neuropathy, peripheral vascular disease, etc. So the approach to the diabetic foot ulcer, just really keep in mind that your lifetime prevalence of developing a diabetic foot ulcer is 15% if you are diabetic. So you really do need chronic care. You need chronic follow-up. So every diabetic who comes for the HbA1c or their sugar control needs a foot examination. And if not able to do a foot examination, we can always involve the podiatrist, which we call the gatekeeper of the diabetic foot. Just to have a look at the nails, make sure the foot is well moisturized, make sure that there's no micro trauma, make sure that there's no infections between the toes as well. Patients often don't know how to protect their foot against micro trauma. They wear the wrong shoes, they expose their foot to heat, to animals, to unhygienic shoes or footwear, and this all contributes to massive infections in the foot that can go unmissed for a long time and end up in major amputation. So diabetic foot amputation or diabetic foot infection, as I said, it occurs when there's pressure or micro trauma. So pressure typically occurs under your metatarsal heads, and that's where you'll find the ulcer, in the pressure sensitive areas. There's an interruption of your cutaneous barrier, and then an infection occurs. In patients with multiple infections, we don't see staphylococcus anymore. We start to see streptococcus, we start to see anaerobes, and this then can lead to gas gangrene. So we really want to prevent this, especially multiple courses of antibiotics for these patients. Just take note, if you have given Augmentin and there's no response, to please send the patient through to a specialist. So then a chronic wound cycle of persistent inflammation and infection occurs. So some patients don't develop gas gangrene. They have this chronic ulcer that's non-healing, that's in stasis, that's unable to granulate there. And that ulcer actually prevents them from completing their activities of daily living. They then get significant sepsis in the rest of the foot, which spreads to other compartments. And like we said, systemic infections as well. So how we score the foot. Essentially, we look at the foot in rooms. We can then identify what kind of infections are present, if there's foot ischemia, and then if there's an ulcer present as well. So the SVS Wi-Fi classification system is really the most accurate one, I find. We've previously used the University of Texas and the Wagner system, and these don't really quantify our ischemic component. So in diabetics, it's very important to quantify that. We see that a lot of diabetics have abnormally high ABIs, and that happens because of the calcifications of the macrovasculature. And we want to then do toe pressures for them. A patient with a toe pressure below 30 millimeters mercury really has massive risk of developing a diabetic foot sepsis. We see that the risk is still there above 30 to 59%, 30 to 59 millimeters mercury, and then above 60, we quantify them as normal, so they get a score of 0. So we calculate that together, and we see what the score is. And we then stage this patient. We stage them so we can refer them. And this can be done in rooms. Toe pressures, sometimes it's a difficulty to do in rooms, but if you can feel a pulse, it's definitely a positive sign for the patient. If you can't feel a pulse, you're a little bit worried about the foot, you're worried about how to quantify the foot, definitely a cause for referral in these patients, especially if they have skin or tissue loss. So the Wi-Fi classification is a prognostic factor or tool for lower limb amputation. And as the stage progresses, there's an increased risk for major amputation in these patients. And stage 3 patients really need to be referred to a vascular surgeon. So in addition to the general surgeon, you also need a vascular surgeon to assess the arterial disease and to plan revascularization in these patients as early as possible. Because if you do have an ascending infection, it might be too late. So our team, quite a big team that we refer to usually and we take referrals from. We work with general practitioners, with several surgeons, endocrinologists, and specialist physicians, dietitians, physiotherapists, podiatrists, wound sisters, and then orthotists or prosthetists. So we typically have meetings with all of them in the same setting and then discuss our patients that we have on the roll. So our general practitioner, very, very important first point of contact. The general practitioner can really initiate the preventative measures, help with education and risk factor management, and identify the diabetic foot with the tools that we've explained now. Initial imaging and labs are easy to do from a general practice, and we welcome just any kind of opinion that's asked, or just looking at the imaging, even if there's some unsurety of what to be looking for. We also try and score the foot to be able to refer adequately in the initial assessment, and then work up the patient for their comorbidities and the sugar control. So in terms of surgery, I want to reiterate that previous amputation is an important and independent risk factor for further amputations, and that's why we see above 60% of patients actually have a repeat amputation in 10 years' time. So when working with a multidisciplinary team, you want to involve your general surgeon for infection control, for medical and surgical debridement and amputation, and typically to stand in the team as a risk controller, and then as an early action taker when it comes to infection control. Your orthopedic surgeon needs to be involved for your Charcot foot, your osteomyelitis, and we typically have surgeons that we refer to, and that we even can ask an opinion for. Our vascular surgeons, as I've mentioned, help us with our peripheral arterial disease component, and they can usually assess the patient and then let us know if the patient is for revascularization, and if they are not for revascularization, and at what level of amputation the patient probably will be suited for. Endocrinologists play an important role in the comorbidity management. Metabolic syndrome, cardiac disease, diabetic control, definitely. So a lot of patients who have limb loss are on the wrong medications, and we know that they are not always adherent to their medication programs, but we really want them to be on the correct medication. We want them to manage their HbA1c at a level less than 7.2, so that we can actually avoid these complications in the long term. So a dietitian is integral in the team. We ask our dietitians not just to help with malnutrition. So we know malnutrition is related to weight loss, poor nutrition, breakdown of skin, and poor or delayed wound healing, and that really is related to the lack of arginine, to the lack of glutamate, and we want to make sure that our patients have their micronutrients aspect of their wound healing also sorted out. We want to improve the relationship with food with these patients, and then have a sustainable control of their sugar levels. So dietitian provides dietary advice which is tailored to each patient and their comorbidities. So in our nephro patients, we want to make sure that they see a dietitian, especially because they have multiple comorbidities at play, and the standard dietary program might not work for them. Physiotherapists, pre and post amputation, they really help us with active lifestyle, stump care. They prescribe exercise routines that are specific to the patient and how much they can handle. So very important. After amputation, we want them to regain gait, balance, and we want them to be able to offload that limb. And the physiotherapist plays an integral role in the hospital and out of the hospital. And I find that they carry usually a good referral program for these patients. They make sure that the patient is seen before and after amputation, that the patient improves their daily activities of living, and they improve their stump care as well. Podiatry is the gatekeeper of the foot. They help with foot hygiene, barrier protection. They help with nail and foot care. They help with early detection of ulcers and infections, and really the podiatrists assist us a lot. Typically, small infections can come from small breaks in the skin or the skin barrier, and our podiatrists really identify these quite early. They make sure that the nails are clean and healthy. They make sure that they pull ingrown nails, which is a common cause for infection, and they make sure that the foot is well hydrated. Our wound sisters help us before and after surgery. The wound sister cares for the chronic ulcers, in assistance with the surgeon, of course. They help us with our post-operative wounds. We really have an array of wound therapies to use, and it can sometimes become complex when you have big exudative wounds, thick slough that you need to debride. or a patient who's post-amputation who's just not healing because of peripheral vascular disease. We want to get our assistants here with negative pressure, with chemical debridement, with different types of dressings, and our wound sisters are integral. They go for specialized courses related to wound care, and they can sometimes assist us when we're stuck with a wound that's not in the healing phase anymore, that's now static. Orthotists and prosthetists help us with offloading. So they have many equipments that they use, from insoles to diabetic foot shoes, to then prosthetics after amputation. And this is very important because it gives that patient the ray of hope that they need. Amputation is a very traumatic experience, and I find that the prosthetist or the orthotist really come in. They give patients options. It's not just you'll get an amputation and you sit in your wheelchair. There are many options. There are many ways to make you comfortable. There are many ways to improve your quality of life, and this is what they enforce as well. We typically also rely on the prosthetist and orthotist to tell us when the wound is ready for coning, when the wound is done with coning, and what type of prosthesis the patient needs. So, as you can see, every patient will get tailored treatment. So at the end of every week, we sit down, usually with our diabetic team, and we look at how the risk factors can be decreased. So we pull up a patient on a PowerPoint just like this one. Everyone looks at the wounds from the beginning to the end. We take 2 weekly pictures at least, depending on how urgent the wound is. We try and optimize the patient's physiology. So from a medical point of view, a surgical point of view, and allied health point of view as well. We help with infection control. So any patient with early signs of infections will be flagged by the wound sister, the podiatrist, or myself, and then that patient will be treated as a red flag. We provide wound care, and we relate to each other how the wound care is going, where the problem areas are, and what dressings were changed. We also speak to our wound companies to assist us. They do have representatives who can come and help and advise on what wounds, how wounds need to be treated, and which dressings would be optimal. We do mechanical offloading for the patients, and then we see how they do during the offloading. So there's no point in prescribing something and then leaving the patient to their own devices. We really go back every second week and we see, did you also improve on the medication? Did you also improve on offloading? Is your insole working? Are you able to balance in your prosthesis or not? And that in that way we can then follow up our patients very closely and make sure that we're there for their every need when it comes to their diabetic foot. And if a revascularization is needed, we follow up the patient afterwards. We make sure that their wounds are healing. We make sure that the amputation was done, or alternatively that there's no signs of early ischemia post-revascularization, and we communicate with other specialists. So that's my team over there, just a quick photo. Very important that as an individual in the team, you should be able to give feedbacks on the difficulties that we are faced with these patients. Some patients are not taking their medications, they're not using their prosthesis, and that's important from every perspective to see that, to make sure that we counsel the patient, we make sure that we educate them again and again, and it often takes more than 3 times of sitting down with the patient and just reassuring them, checking in with them, referring them to the correct specialist. We make sure that there's an easy referral system between us to make sure that we write reports. We make sure that we help the patients get to the specialist, that they have appointments, and that they have a reliable feedback after that. And we red flag patients. So we make sure that the patients we have seen and have red flagged, that they get earlier dates, that they've seen earlier, that they get admissions if needed. We then write a progress report and we file it with each patient so that we can go back, look at the photos, and check how our progress has been. And we discuss our morbidities and our mortalities and what went wrong, or what went right, definitely, just to tailor our treatment more specifically to each patient. So future considerations. Currently, we're not, or generally, doctors are not doing scheduled frequent checkups specifically for diabetic foot. And that, as you can see here, is very important. we need to make sure that we don't have our increased amputation rate with these patients, because it does increase their morbidity and their mortality in hospital. We found that in many studies it shows that you can't return to your normal activity, and you can demise in hospital from either comorbidities or other infections, especially ischemic cardiac disease and myocardial infarction are very common in these patients. So we want to make sure that they don't end up in hospital. Prevention is key here. So we invest in patient education and preventative measures in the primary healthcare setting, moving all the way up to the hospital setting. And we want to make sure that the patients know what the roadmap of treatment might be for them, so that everyone is educated, and we refer back to the primary physician who saw the patient. The other pillar of treatment is early and assertive sepsis control. So we want to identify organisms early, and we want to take them in for either chemical or surgical debridement as early as possible, and then make sure that there's adequate healing in these diabetic feet that we are treating. So our long-term goals will then be to achieve tissue healing while maintaining adequate function and then weight bearing for ambulation. We want to give targeted antibiotic therapy, and we want to offload the foot in the long term so that we don't get recurrences. And then the goal here is actually to prevent life loss, of course, but to also help with limb sparing. A lot of these limbs can be saved. We don't have to see them as necrotizing fasciitis or Charcot's foot. They can be stopped in the early setting to prevent complications. Thank you so much.
Thank you, Dr. Westhuizen. There's a couple of questions that have come through from the chat. So the first question is asking, at what level of HbA1c do you see patients at the highest risk of developing foot issues that would require amputation?
So anywhere from 7.2, I've seen patients with diabetic foot ulcers, in my experience, at 8, at 9, at 10. So it really depends not only on the HbA1c, yes, it's very important, but also on the comorbidities. So that's why I say we should approach these patients individually. But even if the HbA1c is normal and there's a diabetic foot ulcer, there could be underlying peripheral vascular disease. So we still want to refer the patients even if the HbA1c is normal.
Thank you so much for that. And then there were other questions raised about the members of the multidisciplinary team. So the questions here around the role of the occupational therapist and the diabetic educator. So just in your opinion, in terms of the roles of these two in the multidisciplinary team.
Sure. So the diabetic educator is very important. We find that the diabetic educators are not frequently marketed. They're not accessible to patients, and they really should be. I think they play a very important role. If we could get more diabetic educators in and around the hospital, it would be very beneficial, because that's where we struggle the most. We really have to enforce our mission and our vision with these patients over and over again. And I find that the diabetic educators come from a place of warmth and empathy, and they can discuss things that we might not be able to reach, and that's the power of a multidisciplinary team, really. With the other specialists, occupational therapists, honestly, we don't refer that many patients, but they can also work in addition with the physiotherapy team to help with stump post-amputation stump management, and then coning as well.
And then another question here around, if patients gain excellent glucose control after amputation, do they reduce their risk of future amputations?
So that hasn't been proven in studies, not specifically, but generally the patients with better sugar control are able to then manage their comorbidities a little bit better. So we hope that we can do a focus study on that in the future and then see what happens with these patients. But that's the hope. That's hypothesis, definitely.
Okay. Thank you so much. I'm just looking in the chat. I'm not seeing any further. Oh, yes, sorry, I missed a question. There's a question here around what is the role of compression stockings or garments in terms of the management of diabetic foot?
So we use compression stockings and garments, typically with our chronic venous insufficiency patients. They typically get venous stasis ulcers, and they do need compression stockings or garments as conservative management in the initial phase. When these patients develop ulcers, it's typically different to diabetic foot ulcers. It's a different disease process, but you often see them together. So with the diabetic ulcers, I wouldn't apply any pressure component at that stage. I would rather look at the wound, see why the wound is in stasis, and then manage it from different aspects. If there is a situation where the wound is not healing, the patient's been on compressive stockings, and the patient also has a diabetic foot sepsis, it's definitely an indication to refer to the vascular surgeon, who can then help in other settings. So they can control the venous stasis by several methods, and one of them being RFA of that venous stasis. So that's where we get our input from the other specialists. But in the diabetic foot setting, I wouldn't use a compression stocking. Well, you'll look at the patient and just explain that to the patient and say that we don't want a concomitant infection here. We want to manage the wound and just see where it takes us, and that could be considered later on.
Okay, so just a follow-up question to that, because I know you're saying that in the setting of a diabetic foot, you wouldn't necessarily recommend a compression stocking. So the follow-up question would be, prior to there being an actual sort of ulcer, would a compression stocking perhaps prevent an ulcer? Is it something that you can use as a preventative measure?
Yes. So with not with diabetic foot sepsis, with chronic venous insufficiency, if you see signs like lipodermatosclerosis, if you see a champagne bottle deformity in that leg, yes, you can definitely use a compression stocking. If there's no ulcer present, and the patient is a diabetic, that's good for the patient definitely, and it's not a contraindication to a stocking.
Okay. Then there's another question here around, what are the recommended dressings that can be used for the ulcers?
Okay, so we have several. We look at specific wound factors when we decide on a type of dressing. We work with special wound companies for that as well. So you can start with antiseptic dressings. If there's any kind of sepsis involved, if there's slough involved, you use different dressings. So for slough, we'd use our intrasite dressings, our hydroxyl dressings, just to debride that tissue a little bit. For infection, you do use antiseptic, or for exudative wounds, you'll use adaptic treatments. So adaptic would be one of them. Inodine would be another one. Meloderm could be a very, very helpful adjunct because it also is antiseptic in these cases. But the real problem there with that diabetic foot ulcer, after you've done the wound care, should then be the offloading as well. So don't forget that. There are many other dressings that you can describe. If you want to help with granulation, you can use Granuflex. If you have a pressure component, you can offload that a little bit and control your exudate a little bit with aloe vera dressings. So it really depends on the wound and what the character is, and it can be a little bit complex. So you really want to have a look at the wound with the wound sister and see what is needed specifically to the patient. With major infections, dressings won't help. You need a debridement, you need a cleaning of the wound, either in rooms or in theatre.
Okay, thank you. I'm just having a look here. I'm not seeing any new questions in the chat. Let's just give it a moment. Just want to see that I haven't missed anything. Okay, there was a question around if there will be, the recording will be shared. Just to let everyone know, we will be sharing the recording link of this meeting. I'm not seeing any further questions in the chat. So I think with that being said, thank you so much, Dr. van Westhuizen. And it was really lovely having you tonight, and really also just an engaging presentation. So we will be sharing this recording with everyone, but thank you so much for sharing with us and sharing with us about your practice and the management of diabetic foot.
Thank you so much. Have a lovely evening.
Oh, sorry, there's two screeching in questions. I just kind of slid in at the end there. So one question slid in there is asking, how is honey as a dressing? I haven't heard that question before.
Oh, yeah. So honey as a dressing, we often find that in our Meloderm dressings, or it's a honey dressing. Really helps as an antiseptic. The patients love it, and we've seen really good results with it in the primary setting as well. So I often prescribe it to patients with minor wounds. That really helps them to prevent major infections.
And would you prescribe the dressing, or would they be advised to use store just any kind of honey, or would it be the actual sort of?
No, so the dressing's name is, or the ointment's name is Meloderm. When the patient comes in, I actually dress the wound myself the first time. So I make sure I have a look at the wound myself. I do the dressing and show the patient exactly what to do. It can be quite confusing, especially now if you're using multiple wound dressings and multiple adjectives. So if you do your honey dressing and you want to add some Gelonid or Adaptec, or you want to add something else, you really have to see what type of wound you are dealing with. But honey is a very good adjective. You can get it over the counter at discount clicks, and even your Netcare pharmacies has your honey ointment.
Perfect. Then another question here around, what is your take on laser therapy for wound care?
Wound care in general, I won't be able to comment on, but for diabetic foot sepsis, definitely not a fan of laser therapy. I haven't seen many studies on laser therapy. We have studies on other adjuncts, like grafts, granulomatous injections. We have studies on hyperbaric oxygen, topical oxygen, but laser therapy is far and few in between. I think there is a benefit in some plastic surgery procedures. Unfortunately, I'm not a specialist in that area, but for diabetic foot, for the meantime, it's not studied. I wouldn't use it.
Okay. And then a question here asking, when should a person refer a patient with diabetic wound to a diabetic foot wound, to a surgeon?
So if you scored the foot and you found that there is foot abnormalities, anatomical defects like ulcers, there's foot ischemia, and there's signs of sepsis, you need to refer immediately. Actually, the earlier we see the ulcer, the better. Ulcers can change into septic wounds within a day and a half. And I've seen that many times, patients presenting with necrotizing fasciitis. So you want to present, or you want to send the patient over as quickly as possible in that case. So that's where foot scoring really comes into play. And often what happens is we're so far apart. It feels like we're worlds apart. We're not able to communicate with each other, and the door should be open, even for questions. If you're worried about something, phone, we'll give an opinion, send a picture with the patient's, obviously, their consent. We'll have a look at it. We'll have a look at the imaging. Even if it's not for referral, at least we know. At least we know we won't see the patients in 2 weeks in casualty with pus draining from every angle of the foot, and we have to do a major amputation. So, yeah, I would suggest that.
Okay. And I think this might be our last one. So the question here around, what are your thoughts on PRP, so platelet-rich plasma injections for poorly healing ulcers?
Okay, so I've looked at some studies. I know there were a few studies done. One was done in Victoria at one of the hospitals I've worked at before. There's another study that I think they're launching soon, a pilot study. So I'm having a look at it. I've looked at the pictures and I've looked at the studies. I can't give my opinion on it just yet. I just want to see what we're going to do in the future, and then which patients they would get into their control group and the active plasma or injection group, and then just, yeah, form an opinion after that. But yeah, it looked quite positive from what we're seeing. Can't give a full opinion if I would use it at this stage.
So still in the early days.
Yeah.
Okay. All right. Now I think that then covers it then. I'm not seeing any new questions. So thank you so much. And yeah, thank you to everyone who's joined. We will make the link, the meeting recording available, and wish you all a lovely evening.
Thank you so much. Have a lovely evening.
Thank you. Bye.